Bismillahirrahmanirrahim. Let's see the pelvic inflammatory disease or PID, which is associated with the upper genital tract infection. Usually, this infection ascend from the lower genetics and then go ascend into upper genetics. So, the most common cause is the chlamydia and the gonorrhea. Okay, so we see their prevalence. Let's see their pathophysiology, diagnostic criteria, complication, and the management. Okay. So, what is prevalence? 1 million over the year women present in the USA, and 2.5 million office visit, and 1 to 5 to 150K hospitalized and due to complaint of PID. Okay, and 10 to 20 out of 1,000 women, reproductive age women in the high income countries, so they present with PID, and 85% of the sexually active female, so they present with the PID, and it's not common in our community because there is no sex before the marriage, so it's associated with the sexually active female. Okay, and 15% after the procedure, if any the procedure which break the cervical mucus barrier, so that lead to PID. Okay, how this pelvic infection spread? So there are three ways. Either it's spread via the hematogenous, mean via the blood. Most common example is the pelvic TB, or via the lymphatics. Endometritis is the most common example. And the PID, which we are discussing now, it's ascend from lower genetics to upper genetics. Let's define the upper genital tract and the lower genital tract. So this is the from this borderline, and the upward structure like the endometrium, uterus, fallopian tube. So these are considered as the upper genital part, and from below this, the like the vagina, cervix. So these are considered as the lower genital tract, where you see high level of microbes, but there are a low diversity. Mean mostly they are lactobacillus, while in the upper you see low number of microbes, but they are and the variability is high. You see the lactobacillus, bacteria, bifidobacterium, pseudomonas. So you see, but in this case, the dominant one is the lactobacillus. Okay. So if there is any infection, so this the microbe which is eubiasis, they change into dysbiasis, where they are replaced by the anaerobes, the streptococci, different infective agents can replace this that cause the infection. Okay. So what is the protective mechanism of genital tract? So in the vagina, you see the stratified squamous epithelium, acidic pH, and there is approximate closure, so which prevent from the infection. And in the cervical, there is mucus, so mucus plug, especially during pregnancy, which prevent from the infection. Also, there are antibodies present in the mucus which prevent the infection. Okay, and in the uterus, uterine, you see better, there is monthly menstruation, so that's why the endometrium shedding, which prevent the growth of the microbes. Okay, and better, there in the fallopian tube there is a serial movement downward in each menstrual cycle, so that's why this decrease the risk of infection. Okay. If the barrier break, so what will happen? So like in the sexually active girl, so this infective agent ascend. How they ascend? They, for example, they ascending from downward to upward, so they attack the cervix, so this cause the cervicitis. Okay, then they reach into the endometrium, so they can cause the endometritis, but minimal. Why? Because there is monthly shedding. Okay, so this decrease the endometrius, especially in the reproductive age or in the childbearing period. Okay, and then this infection ascend toward the fallopian tube. So this involves the fallopian tube. Okay, so this is and involve it can reach to the ovary. Okay, so the condition is known as acute salpingo-oophoratus. Salpingo means the fallopian tube, oophoratus means it's involved the ovary. Okay, acute salpingo operators. There are different type of the salpingitis, for example, endosalpingitis, interstitial salpingitis, and peri. So endo means it's limited to the mucous membrane, and the interstitial, which mean involve its muscle, and the peri mean it's also involve the outer part, okay, outside the fallopian tube, okay. And there is the other form which define the cateral or suppurative cateral, which is mild form suppurative, where you see the pus formation. Here just see the edema, and in the suppurative, so you can see here this the acute salpingo-affritis. So you see the inflamed the fallopian tube, you can see here. Okay, so endo, interstitial, peri, endo mucus, muscle and mucus, and peri outer surface, then the inward. Okay, and in the cateral, it's a mild form where only mucous membrane is involved. So this causes the edema, congestion, and the serious exudate. While in the suppurative, all layer are involved. So there is pus formation, which cause the peritonitis, mean which involve the peritoneum surrounding this part. Okay, and adhesion and abscess. Okay, so there is no gangrene in the fallopian tube. Why there is no gangrene in the fallopian tube? Because there is a bilateral supply. So the fallopian tube is supplied by the uterine arteries as well as the ovarian arteries. Okay, so there is no gangrene in the fallopian tube. Okay, so if you treat this condition, I mean acute PID or acute salpingo-affritis, so the pelvis become normal. If it's untreated, so this lead to chronic PID, okay, or it can lead to the TOA, mean tubo ovarian abscess. Okay, so there will be abscess or pus formation in the ovary and the tube. Okay, so this is tubo ovarian abscess. Or so here you can see where you see there is a pus formation in the ovaries as well as in the tube. Okay, or it can lead to the peritonitis, because here is the peritoneum is which covering on the upper side. So this cause if the infection separates, so it can lead to the it involve the peritoneum, so which cause a peritonitis. Okay, so these are so this is the mechanism of infection. So infection separate from downward to upward, cervicitis, endometriosis, acute salpingo-affritis, then they lead to the chronic PID, TOA, or peritonitis. Okay, so let's define the acute PID. So it's upper genital tract infection, where you see the salpingitis, affritis, peritonitis, and rarely the endometriosis. Okay, so how the patient present, they usually present with the fever, malaise, and headache, and there is history of mostly the organ procedure, so which break the barrier. So that's why it causes a PID, and acute lower abdominal pain, and they present with the vaginal discharge, which is foul smelling and purulent. Okay, so which is positive for the culture. And what the signs you see, you see the fever, which is more than 38.3 Celsius, and tachycardia, and there would be a vaginal discharge. Okay, and you see the tenderness, because why tenderness mean when you touch these part, so this cause the pain. Okay, so especially if you touch the lower abdomen, or if you press the lower abdomen, and as you release, so there will be a rebound tenderness. Okay, when you put the pressure over the lower abdomen, and when you release your hand, so it's cause the pain. So this is no rebound, and there is a cervical motion tenderness. Mean when you touch the cervix or remove the cervix, so this cause the pain. So this is cervical motion tenderness. So these are the sign of the acute PID. Infection route, as I mentioned, so most common is the ascending, and the other is there is a lymphatic or local or blood. Okay, so what is the etiology? Etiology is most common is the Neisseria gonorrhea, and then the chlamydia trachomatis. Okay, so the 80%, 20%, then you can say there are limited case which involve the other, but most of them these two are involved. So if the infection due to gonorrhea, so there is a rapid and intense inflammation. Okay, while in this case, in the trachomatis or chlamydia, there is a slow progression. So there will be mostly they initially they are silent, mean they are asymptomatic PID. So that's why they are unaware of this condition. So this lead to what? This lead to infertility and ectopic pregnancy. Infertility and ectopic pregnancy. So this is mostly associated with the trachomatis or chlamydia. So or in the gonorrhea, if it's mean when both are involved, mean it's followed by the trachomatis. So this causes the infertility and ectopic pregnancy. So because it's mainly associated with the chlamydia, not with the gonorrhea. Okay, when both are involved, so this lead to infertility and ectopic pregnancy. What are other infective agents? Other are the aerobes, E. coli, staph group B, aerobes, anaerobes, mycoplasma, and actinomyces is really related to intrauterine contraceptive devices. And I suspect that TB if the PID in the virgin, mean she had never experienced the sexual intercourse, so you should think of the tuberculosis. Okay, what are risk factor for acute PID? So if there is a lower genital tract infection, or if the first intercourse age is less than 25 years, and if there increase the frequency of the intercourse of if there is the increased number of sexual partner, or if their marital status, if you look at, so 33% in nulliparous, mean they are not married. Okay, and the sexually active woman. So these all are the risk factor for the acute PID. So what there are some factors which increase this risk. For example, if the partner is untreated, so this will increase the risk for the PID if he is using intrauterine devices. Any procedure, for example, D and C, HSC, hysteroscopy, which break this barrier. So that's why this increase the risk for the acute PID. Okay, if some factor will decrease this risk, for example, they are using barrier method, for example, condom, or she is taking the oral contraceptive or pregnancy, because this for the mucus plug which prevent the ascending of the infection, and tubal ligation. So tubal ligation also decrease the if the tube is ligated, so this decrease the ascending of the PID. Okay, and what investigation you do for usually for acute PID? Although there is complex, but you normally see the blood. So in the blood you see the increased total leukocyte count, increase the differential leukocyte count, and they shift toward the left, and there is ESR level will be high, and the C-reactive protein level will be high. Okay, so these are usually you see in the acute PID, but you should rule out the other the differential diagnosis. So by going for ultrasound, for example, you rule out the ectopic, complicated ovarian appendicular mass, or degenerative myoma. So by look you can check it by the ultrasound. Okay, to confirm your diagnosis, if you are still suspected, so then you go for the laparoscopic, so which confirm your diagnosis. Okay, so there is some CDC criteria which also define how you diagnose the PID. So I have created a mnemonic which is acute, warm up, etc. Okay, let's see. So there is minimum diagnostic criteria, additional diagnostic criteria, and the definitive diagnostic criteria. So minimum which increase the sensitivity, but not the specificity. So mean there is sensitive, mean it's you can consider PID, but the this additional criteria specify them, and there is some confirmational test. So let's see what is minimum. Remember the acute. Okay, so A, adrenaxal tenderness, cervical motion tenderness, uterine tenderness. Okay, so and T mean tenderness. Okay, while warm up etc. WBC, you see the increased and you see the agent, infective agent. For example, in the culture will be positive for gonorrhea and trichomonatus, and you see the M mean mucopurulent discharge. You will see in the or vaginal discharge. Okay, and you will see the increase the ESR level, and increase the temperature, Okay, and you see the C-reactive protein level high. So warm up etc. So this is additional. At least one must be present. At least one must be present. So how you can confirm? By looking at the biopsy to rule out the endometriosis and go for the transvaginal ultrasound or MRI. Show the thick fluid filled tubes and without free pelvic fluid. So tube ovarian complex or Doppler study which show that the blood. Okay, so you see that tubal hyperemia. Okay, and in the laparoscopic you see consistent finding of the PID. So acute warm up etc. And these are the biopsy, ultrasound, and the laparoscopy. Okay. So these are investigation. What are the complication of PID? Complication number one is better abscess or septicemia, mean the infective agent are moving in the blood. Okay, and the chronic PID if not treated, and the tubal obstruction or infertility as I mentioned. Okay, which also due to fibrosis and adhesion, and there is increased risk of the ectopic pregnancy. And the other important the complication is a Peter-Hag-Curtis syndrome. So this is usually due to the septicemia or due to peritonitis because they involve the hepatic, I mean liver. So this infection spread toward the liver. So you will see the perihepatic inflammation, and there will be adhesion, especially under the diaphragm. So this is the Peter-Hag-Curtis syndrome. Okay, Peter-Hag-Curtis syndrome. So you will see for example, if there is inflammation in the liver, so you will see the finding of the right upper quadrant pain, which you may consider usually in the cholecystitis. Okay, so but in this acute PID cause this problem. Okay, so this is you can see the perihepatis, the inflammation and adhesion. Okay, so in this picture, the laparoscopic, you can see the adhesion over here. Okay, so and here are peritoneal adhesion. Here you can see perihepatis. So acute PID, perihepatic inflammation and adhesion. So etiology vascular or the transperitoneal dissemination of gonorrhea or chlamydia. Okay, mostly they are chlamydia. So violence settings, so we call it, these are violence setting which cause adhesion between liver and the diaphragm. Okay, and the sign and symptom, right, per quadrant pain, pleuritic pain, tenderness at the right upper quadrant on palpation of the liver, and the differential diagnosis acute cholecystitis, or there would be a pneumonia, but you can confirm by going for the investigations. Okay, mortality 5 to 10% if there is a tubular ovarian abscess. Okay, and the treatment is same as we treat the PID. How we treat the PID? Let's see. So treatment is look for the mild PID or the severe. Mild mean the condition is diagnosed and it's a not complicated condition. So this is OPD patient, mean outpatient. Okay, and if the severe condition, then go for the hospitalization. So in the mild PID, you give the ceftriaxone 250 mg single IM and plus doxycycline 100 mg oral for 12 hours and give for 14 days. Or you can add the metronidazole plus or minus, because this is usually used for the anaerobic infection below the diaphragm. 500 mg oral bid and for 14 days. Okay, so this is single IM dose. These are for 14 days, these two. Okay, in the severe condition, you give everything IV, mean IV fluid, IV analgesic, IV antipyretics. So IV antibiotics, mostly we use the ceftriaxone or the doxycycline. Okay, so ceftriaxone, so these are dosage for the ceftriaxone and doxycycline. Okay, so this is the treatment of the mild and the severe PID. Okay.